Ms. Scott, just before we begin again, I think some people may have noticed you have a slight hoarseness of voice and a slight cough, but I understand, just for their reassurance, you took a PCR test over the weekend and it was entirely, well, it could, either negative or positive. It was negative.
Indeed, that's correct, yes, sir.
So you are not suffering from COVID, whatever else you may have seasonally infecting your voice.
That's right, sir. Dr. Entwistle, I'm going to start this session asking you about your knowledge of risk of hepatitis, and I'll come on later to deal with HIV. I think perhaps the best way to start us off is to go back to your witness statement, WITN 6917001, and to page 24, please, Paul. And this is what you say at paragraph 87. I had been aware since the 1970s, after the identification of hepatitis B, that there was a condition given the title non-A, non-B, for want of a better name. I was also aware that throughout most of my time at Oxford, there were no specific tests for it. It was acknowledged that this condition posed a risk of blood transmission. And then if we pick it up again at paragraph 90, please. You were asked questions about your understanding of how serious hepatitis C or non-A, non-B could be, and you say, my understanding was that hepatitis B was the most aggressive infection, but that the other forms, including hepatitis C, could nevertheless lead to chronic liver disease, possibly with ultimately fatal consequences in some cases. Now, I'm just going to show you a document to see if we can nail down the date or thereabouts by which you would have which you knew that hepatitis C could lead to chronic liver disease and ultimately could be fatal in some cases. Can we have, please, Paul, PRSE 304766? So this is a document called Notes on Transfusion, and we can see there that it's the revised version of 1984. Sorry, I've got the wrong document up in front of me, which isn't very helpful. Find the right document. And if we turn, please, to if we turn, please, to page 3 of that document. In fact, can we go back to page 2? It's rather small writing there. If we can enlarge that. We can see that this is a document issued by the Department of Health, Social Security, with the Scottish Health and Home and Health Department and the Welsh Office for the National Blood Transfusion Service and the Scottish National Blood Transfusion Service. And then if we go over to page 3, we can see that on the left-hand side, if we can enlarge that bit, this edition of Notes on Transfusion, like its predecessors, has been prepared by a committee in the Regional Transfusion Directors, has been prepared by a committee of the Regional Transfusion Directors. Can you recall whether or not you were on that committee?
You say that was 1983?
Yes, it's the revised 1984 version.
I can't recall offhand when I was involved in that committee.
So you were at some point involved in drafting?
At some point, but I cannot, unfortunately, I can't remember exactly when.
Can we... we've heard some evidence last week that this document was the definitive publication from the transfusion service to be used by those carrying out transfusions, transfusion medicine in hospitals, so for clinicians on the front line. Is that how you understood it to be used?
It could well be, and obviously anyone who's involved in transfusion should have pretty good knowledge of what they're doing.
Can we turn to page 19 of this document, please? So we've got a section there on the right, post-transfusion hepatitis, and it's the bottom paragraph that I wish to draw your attention to. Very similar illnesses can also be caused by other viruses, including the so-called non-A, non-B viruses. The latter are also transmissible by transfusion, but as yet no specific laboratory tests have been developed to identify them. The incubation period is also variable, extending up to 70 days or more. The clinical course may be acute or chronic, leading to cirrhosis. So is it fair to assume that even if you weren't involved in the drafting of this particular document, you would have known what the contents of it were?
Yes, so certainly.
So if we're trying to pin down a date by which you would have known about the chronic course of hepatitis C, non-A, non-B in some cases, and the seriousness of it, I was aware of that even before this document came out. Were you aware of it, do you think, by the time you arrived at the Oxford Transfusion Centre as the director?
Yes.
So by 1980, you were aware of the seriousness of non-A, non-B hepatitis?
Yes.
Can you recall what, how you became aware of that information, what it was? What it was that led you to understand that?
I don't think there was any specific article or information which I gleaned on that subject, but I was certainly aware of it from my general reading and knowledge of the subject.
I'm now going to ask you some questions about your view of your role as a director of the Regional Transfusion Centre.
Could I, before you do that, could I just come back to the that document that you had on screen? That's PRSE 304766. And go back to page 2, page which you passed over reasonably quickly. Can we just highlight that, please, Paul? Thank you. I just wanted to ask you about this, really, I think, for confirmation more than for information. The Notes on Transfusion is issued by the Department of Health and Social Security with the Scottish Home and Health Department and Welsh Office for the National Blood Transfusion Service and the SNBTS. The words "for" there could be interpreted in one of two ways. One could mean that it's intended to be given to the National Blood Transfusion Service and those who work in it. The other could be that it's done on behalf of. I had read this, and I want you to know whether I'm right or not, as essentially being issued on behalf. And it may be a reflection of the fact that the NBTS had no direct funding from regional health authorities of its own, but had to rely upon central finance for anything which it was going to publish and send round. Am I right or am I wrong?
I don't recall.
Thank you. It's in that case, it's something which is open for comment in due course by others. It would seem to be, it might be a reflection of the fact that the NBTS was in name, though not necessarily in control and organisation.
I'm going to ask you now about your view about whether or about your about whether or not you considered you had a role in educating your clinical colleagues about the risk of transmission of viruses via blood and blood products. So did you consider that was part of your role?
To be fair, no, I don't think I did.
What about, did you consider it to be part of your role to educate your clinical colleagues more generally about about best practice and transfusion medicine?
That is something which hadn't really figured in my thinking.
Can I take you to a few documents and see if that prompts any recollection? The first is DHSC 302221_011. This is a report from the Central Management Services for Department of Health for the DHSS in 1982, and it's called Blood Record Keeping and Stock Control. And it's a review of, unsurprisingly perhaps, record keeping and stock control in transfusion services and indeed in hospitals. And the report concludes by making a number of recommendations. And if we can turn, please, to page 30, we can have a look at 3 of those. Recommendation 148, it's recommended that centres, and by that they mean regional transfusion centres, consider as part of their role a formal process to enable the exchange of ideas and good practice at operational level for hospitals to whom they supply substantial quantities of blood and blood products. 149, it's recommended that discussion on a formal basis, say annual or 6 monthly, between the medical staff or the director at the centre and the hospital-based haematologist in charge of the blood bank is considered with a view to sharing problems and good practice experienced in blood banking. And then if we go over the page, please, to 160. And then this is a recommendation for haematologists in charge of blood banks, that they are asked to ensure that they discuss with their medical colleagues economies in blood usage. So that takes the chain through. That's not for regional transfusion directors, centre directors. So just pausing there, is this... well, in fact, I'll show you another document before I ask you the question. So if we could then turn, please, to NHBT 40476. And we can see here this is a DHSS circular from 28th of February 1983 to regional administrators, district administrators, and so on. And it refers to the blood transfusion record keeping and stock control arrangements. And then if we go over the page, we can see that that's the circular itself. Is entitled Draft, and it's, again, to regional health authorities. The summary, this circular asks health authorities to review arrangements for the supply of blood and blood products and to review concurrently record-keeping and stock control arrangements in regional transfusion centres and hospital blood banks. Its contents have been endorsed by the Advisory Committee on the National Blood Transfusion Service. And then if we go down to the bottom of that page, regional review of policies, to facilitate a regional review of policies, it's suggested that RMOs should convene regular meetings between their regional transfusion directors and the consultants responsible for the hospital blood banks in their regions to consider matters such as current and future requirements for blood, the scope of economies in blood usage, the proportion of plasma-reduced blood to be supplied, the use of ad hoc deliveries and the amount of stock which becomes time expired in blood banks. The meeting should also provide the forum for the exchange of ideas as to what constitutes good practice in the region with regard to blood supplies. So, first of all, do you recall seeing either the report that we looked at first or this circular? Are those documents that came to your attention, do you recall?
I must be honest, they did not come to my attention.
Do you recall whether or not the Regional Health Authority took any steps to arrange regular meetings between yourself and the consultants responsible for the hospital blood banks?
Not that I'm aware of, no.
You mentioned earlier the meeting of the Regional Blood Club.
Yes.
How did that come about? Was that as a response to these recommendations or this circular, do you think?
I don't know, because that system of regular meetings was already in place by the time I came to Oxford.
So it couldn't, just by the dint of the chronology, be a response to what was happening in 1982 or 1983?
That's my imagination, yes.
So in terms of meetings between yourself and your clinical colleagues running the blood banks and indeed carrying out transfusion practice, you have the regional meeting of the blood club. Were there any other forums in which best practice or exchange of information took place?
Not as such, no. The only other thing I could mention is that we had very informal but regular discussions over the phone with my haematological colleagues in the hospitals as necessary.
And so would that arise where you might be rung up for advice in relation to a difficult case, for example?
That is one possibility, yes. Or if there was some new development or some new recommendation that I was aware of, I needed to pass on.
And might that have included information about viral infections in blood and blood products?
I'm sure that must have been discussed. I can't say more than that.
And in terms of the Regional Blood Club, what was the purpose of those meetings? And what actually occurred during those meetings?
It was a forum for discussion primarily, but sometimes with a specific topic being discussed in more detail.
And can you recall whether transfusion-transmitted infections were discussed at those meetings?
Offhand, I can't recall.
I'm going to move now to ask you some questions about your work on the working party on the care and selection of donors, which reported to the Regional Transfusion Directors meetings. It's right, isn't it, that working party was responsible for drafting the guidance document entitled Care and Selection of Donors, is it?
Correct.
And if we just turn the 1984 version up, we find that at NHBT 53225. Now, is it right to understand that this 1984 version was a revision of the previous 1977 version?
As I understand it, yes, it was.
And so, again, by dint of the chronology, you wouldn't have been involved in the drafting or of the 1977 version because you were you were not in the blood transfusion service at that time. Just looking then at the title of this document, and we can see it's guidance for the selection, medical examination and care of blood donors. Given the autonomy that each regional transfusion centre had, do you know the extent to which this document was followed by other regional transfusion centres?
No, I don't. I had no reason to know what they were doing.
In terms of your own centre, so in terms of the centre at Oxford, would you expect those working at donor sessions, so both the administrative clerk and the medical officer, to have followed the guidance in this document?
Yes.
And would they have received training on and received a copy of this document?
I can't recall whether they would have had that document. They might well have done, but certainly there was some training at the start of their undertaking sessional work for us.
So if we look then at the detail of the document and then ask you some questions about how what your understanding of the donor sessions and how they ran and how donors were selected. We can see in the first page that there is, under paragraph 1, there's some general guidance about the age of donors, the weight of donors, and so on. And then if we, at paragraph 2, again, general guidance about intervals between donations. And then paragraph 4 looks at hazardous occupations, and again, general guidance in relation to, or specific guidance in relation to that. If we then turn over the page, we get to section 2, medical examination of donors. And it says under medical history, a donor is the best judge of his or her fitness, and truthful answers to simple questions about his or her medical history and general health form a large part of the assessment. The donor session clerk should specifically question the donor about the conditions listed on form NBTS 110A and request the donor's signature on form NBTS 110. Any conditions declared should be recorded by the clerk or preferably by the medical officer, most conveniently in the medical history box or the NBTS 101 donor record card or other equivalent document. So just pausing there then, is it right to understand that the first, the system relied on the donor disclosing whether or not they had suffered from the conditions that are listed in the form mentioned there?
Yes, that is correct. And it was inevitable that if they failed to disclose for whatever reason, there's no way that we could prejudge.
So was any training given, or was there any expectation that either the donor session clerk or indeed the medical officer would carry out some kind of assessment themselves of the donor and whether or not they were a suitable candidate for donation? So setting to one side what had or hadn't been disclosed by the donor, was there any other kind of check by those individuals?
No, not really.
So if a donor discloses a relevant condition on the form, then is it right to understand that that would trigger a referral to the medical officer for consideration of whether or not that donor should be deferred or whether or not that donor could donate?
That's correct, yes.
And the medical officer would then turn to this document for guidance as to how to deal with that particular donor.
Yes.
Is it also right to understand the medical officer would ask questions, or would effectively interview a donor who had been referred to him or her in order to get more information about the condition.
I think it would be fair to say they would ask further questions. They wouldn't necessarily interrogate them, but I think have sufficient information to say, yes, well, okay, we can forget that for today, or perhaps we'd better not give blood today, or even take the matter further.
So you would expect there to be some exchange of information once something has been disclosed.
Yeah.
And was there an opportunity for that discussion to take place in private during during a session in the community, or would there have been sessions, at least some sessions, where that discussion would have had to take place in the large room that was where all the other donors and staff were?
It would almost inevitably be in what you might call open forum, yes. But obviously one would try to, shall we say, try and take the patient slightly to one side, so they're not sort of right next to somebody.
And was that a concern that given how reliant the system was on donors being honest about what might be rather embarrassing or difficult matters to talk about, that was being done without much privacy?
It's a consideration which perhaps should have been dealt with differently, but it wasn't.
So let's look then at what was available by 1984 in relation to those who may be considered to be high-risk donors for AIDS. So in 1984, the donor would have been provided with the NBTS 110A. Is that right? So we just looked at the guidance, and it said the donor session clerk should specifically question the donor about the conditions listed on form NBTS 110A and request the donor's signature on the form NBTS 110. Would the donor have been given the form NBTS 110A, or is that something that the donor clerk would have had?
The donor clerk would have had it, but other copies of that leaflet would be available for them to have read prior to seeing the clerk.
And so if we look at NBTS 110A, which is at page 18 of the document we were just looking at, the guidance, NHBT 0053225. We can see that this is appended to the 1984 guidelines, and if we see right at the top there, I think it says NBTS, or the bottom of NBTS 110A, Rev 1983. So we understand that form was revised in 1983. Does that accord with your recollection?
Mm-hmm.
And then you say, this is very important, please read carefully each time you attend. So that would suggest, would it, that this was a leaflet provided for the donor?
Yes.
And then we know from the guidance that the donor session clerk must ask specifically whether or not the donor has suffered from any of the matters set out there, which includes hepatitis, jaundice, or been in contact with a case in the last 6 months. It doesn't include AIDS, which seems to have been handwritten in there with a question mark. Is that, again, how you remember it in 1984?
Well, this looks to me like a possible draft rather than the official document.
Because by 1984, there was the separate AIDS leaflet that had been produced by the Department of Health, and that would have been available at donor sessions, would it?
Yes, there would be separate leaflets which specifically listed risk of AIDS.
And I'll come on to ask you some questions about that in due course. So just sticking then with this and the point in the session at which the donor clerk is asking the donor questions, again, that would be an open session, would it? Those questions would be being asked orally, and they were being asked orally in open session.
That's correct.
And then turning back then to page 2 of this document, we see there it says a more detailed list. So the last paragraph there, a more detailed list follows of conditions which may affect actions taken with a particular donor, whether to accept a donation, to refer the donor to the medical officer, or to decline their offer permanently. Any donor not accepted because one of the conditions listed will, if they ask, be referred to the medical officer. So then they're set out a list of conditions. So these are conditions that both the donor clerk and the medical officer will be taking into account. Is that right?
Yes. I mean, if the donor admitted to any of those, he or she could be referred to the doctor for consideration.
And then we see there AIDS disqualifies, see Appendix 1. We can see Appendix 1 is at page 10. Notes on certain diseases, acquired immune deficiency syndrome, practicing homosexual and bisexual men, drug abusers, both men and women, persons from Haiti and Central Africa, particularly Zaire and Chad, haemophiliacs, and the sexual contacts of all those mentioned must not be accepted as donors. So that wording comes from, does it not, the first leaflet on AIDS?
Yes.
And we can look at that in due course if necessary. And then if we go back then please to page 3 of this document. And down to hepatitis. So if we know that the donor clerk will have asked specifically about hepatitis or jaundice, and if that is disclosed, we can see here that it's referred to the medical officer, and again it says see Appendix 1. So if we turn back to Appendix 1 and to page 11, please, we can see there the guidance that's given to the medical officer. Individuals who give a history of jaundice or hepatitis or in whose blood anti-HBs is present may be accepted as donors, providing that they have not suffered from jaundice or hepatitis in the previous 12 months, have not been in close contact with hepatitis or received a transfusion of blood or blood products in the previous 6 months, and providing their blood gives a negative reaction for the presence of HBsAg when tested in an accepted sensitive method, e.g. RIA. An approved test for hepatitis B surface antigen should be performed each time a donor is bled. Donors whose blood is shown to carry hepatitis B surface antigen shall be excluded from the ordinary donor panel. They may only be considered for reinstatement under special circumstances, and if they have been subsequently demonstrated by appropriately sensitive tests to be persistently negative for known viral markers, HBC, HBE, for at least 12 months and have an adequate level of anti-HBs antibody. So that was the guidance then being...
May I comment on that,
yes.
if I may? That quite honestly, if a donor presented with a history as presented there, whatever the subsequent microbiological tests were as specified there, the odds are that donor would not be accepted anyway.
So if, are you talking there about somebody who has a positive test for hepatitis B surface antigen? Or, because there are two different categories here, aren't there? The one is somebody who gives a history of jaundice, and then those that are shown to carry the antigen.
Those who have a history of jaundice we would not have accepted anyway. And those who certainly have been tested positive, they would be excluded without question.
So am I right in understanding that what you're saying is that despite what this says in terms of accepting those with a history of hepatitis or jaundice, as long as it was more than 12 months ago, in practice in Oxford, that's not what happened. In practice in Oxford, if one disclosed that history, you would not be accepted as a donor.
Yes, we would not accept them.
So is it right to understand that in fact Oxford departed from these guidelines?
Perhaps we were overly restrictive.
And do you recall whether or not you discussed that with any of your fellow regional transfusion directors and explained that that was your practice? No.
No.
Why not?
Well, I would personally thought that reinstatement of those donors was questionable. And if they had got hepatitis B, who knows whether they might have something else as well, which we've not tested for. So I was personally less happy to accept those sort of donors in the future.
And were you also concerned that if you accepted somebody with a history of jaundice, then in fact it may be somebody who was infected with non-A, non-B hepatitis, and applying this guidance, you may be letting such a person onto the panel to donate?
Well, that's precisely what I was thinking. I was unhappy with that particular recommendation. I am also aware, of course, that long before the discovery of hepatitis B, the service was aware of jaundice being a possible marker for trouble. What we subsequently found out was, of course, most of those were not hepatitis A or B or hepatitis C, but might well have been the so-called infectious jaundice, which is a different disease altogether. And it wasn't until specific tests became available that we could define exactly what was what.
How is it that these guidelines came out in the terms that they did in relation to hepatitis, given that you, as I understand it, were the chair of the working committee that was drawing up these guidelines and didn't in fact agree with one of the key recommendations within it?
I felt it was over generous, shall we say. But nonetheless, there were others on that committee whose advice was respected, and I think one has to be cautious in trying to draw up a common agreed policy which everyone can agree to, even though some people might feel slightly different within that.
And so is it right to understand that you would have trained your staff to take a rather more cautious approach than that set out in the guidelines?
In general terms, yes.
And do you think there was a danger that because this was the written guidelines, that in fact some of your staff would have applied the guidelines and not applied the more cautious test that you thought was appropriate?
I honestly can't say.
Can I then, picking up on a slightly different issue, on the issue of consent, which you seem to have raised at a meeting in July 1984, can we turn please to DHSC 302245_002. So this is a meeting of the Regional Transfusion Directors on July 1984, at which you were present. And if we can turn please to page 3. There's an entry at the top there, care and selection of donors, and it's the second paragraph. Discussion took place on the format of the blue form signed by donors and whether this can be regarded as consent. Dr. Entwistle is pursuing this with the Protection Society and will inform RTDs of his findings. And I'm just going to take you to one more document before I ask you about this. It's NHBT 0090316. And this, we can see, it's got a compliment slip on page 1 from you. And if we go then please over to page 2, we can see a memorandum to the Medical Protection Society, dated the 1st of August 1984, from a firm of solicitors, Le Brasseur and Berry. And it says, Dear Dr. Entwistle, re-consent and blood donors, and then it sets out some advice, and at the bottom there's a signature. Is it right to understand that this memorandum was provided by you to the Regional Transfusion Directors meeting? If we go back over to the page, the previous page, for the meeting on the 10th of October 1984.
I can't imagine that was not referred back. In fact, I think it was referred back to the directors' meeting. I was also aware that there had been some difficulties, not in our region but elsewhere, with regard to consent being acceptable or not. But the Medical Protection Society felt that the consent was actually implied, yes.
So is this right? You raised it as a concern at the meeting we just looked at because you were concerned. It had been raised with you, and you wanted to understand what the position was. You
Yes.
then went off and got some advice from the Medical Protection Society, and they appear to have provided you with the advice that they themselves received, and you provided that advice back to the Regional Transfusion Directors meeting.
I'm sure I would have done, but I cannot recall today whether I did or not. I'm sure I must.
All I'm inviting you to consider is that that's what it looks like, because you've got a compliment slip suggesting that attached to the memorandum from the Medical Protection Society.
It's likely that I would have referred it back.
And then if we look at the detail, then if we go back over to page 2, please, Paul, if we look at the detail of what the Medical Protection Society were told, says, second paragraph, your member refers at the end of his letter, I think that's you, to the apparent loophole in our present arrangements, but we do not think there is in fact any loophole. Have Dr. Entwistle or his fellow directors in other centres ever experienced any complaint by a donor alleging a lack of consent? It's difficult to conceive how such a complaint could be sustained. And as we understand it, the prospective donor takes the initiation in contacting the blood transfusion service and expressing a willingness to give blood, and is then sent an appointment to attend a session, and then is asked to read and sign a form which is addressed to the blood donors. In all the circumstances, it points clearly and unequivocally to implied consent. And the consent is implied not only by the signing of the document, but from all the circumstances, i.e. the initial volunteering, the attendance at a session, the signing of the form, and the permitting of blood to be taken without raising any objection. So was that, did that put to bed, as it were, the concerns that had been raised with you about whether or not there was sufficient consent by blood donors?
Because as there had been a case referred to the medical directors meeting from another region where a donor queried whether consent was valid. But obviously you will see from what the Medical Protection Society have just quoted there, they thought it was perfectly valid.
And then, for the sake of completeness, which I probably should have taken you to before looking at the issue of consent, but I'll take you to now, just to have a look at the forms that we do have that the donor would have been provided with to sign during the session. If we can look, please, first of all, at NHBT 001 0861 underscore 004. So this is, we can see halfway down the form NBTS 110. And if we look on the left-hand side under birthplace, it says NBTS 1011, revised 1965 in very small.
I think it's 101/P.
Yes, I think that must be right. And it suggests there Rev 1965. Now, I haven't found, not to say that it doesn't exist, but I haven't found a form between then and 1985. Is that a form that you recognise? It's from significantly before your time, 1965. But is that a form that you recognise? Or do you think there would have been revisions subsequent to that?
I'm pretty certain there would have been revisions to that.
And so the next one that I've been able to find is at DHSC 302277 underscore 068. So this is the 1985 version, and revised 1985, and then it says to blood donors. So this seems to be a later version than the one we looked at on the back of the guidance, the 1983 version. Again, it doesn't appear in the 1985 version to have any reference to AIDS, but it does in the list of conditions. But it does say, please read the leaflet about AIDS. So the donor is directed to the AIDS leaflet. And then tells the donor that all donations will be tested for the AIDS antibody, and then the donor is asked to sign below on this form to show that they've read the notice and they agree to their blood being tested. And then lastly, the 1990 version, which is at NHBT 306682 underscore 008. And it's in a slightly different form here, and it's entitled Declaration by Donors, and they are asked to declare various different matters, including that they haven't had an infectious disease in the last 2 years, or been in contact with an infectious disease, haven't lived abroad other than in Europe, one about inoculations or vaccinations, and then a list, they haven't had any of the list of the following, which includes jaundice, doesn't include AIDS, but then again directed to the AIDS leaflet and say, I am not at risk, and then agree lastly that the donation can be tested for AIDS antibody and other infections. So certainly from 1985 to 1990, were those the forms that were in use at the Oxford Centre?
Yes, they are.
Moving on then to deal specifically with AIDS, you've told us in your statement that you first became aware that AIDS was a medical problem in 1982. Can you recall the circumstances in which you first became aware of AIDS?
From general press and medical press.
And when did you first become aware that that AIDS or HTLV3 was caused by, or could be caused by blood or blood products.
Well, which is it? Could be or is?
Is.
Was caused
Was caused.
as opposed to what might be caused.
Well, let's start with might be caused.
I was aware right from the start that the question of infection with the AIDS virus was associated with transmission via blood in some form, whether it was through transfusion, which is only one form, but through other unusual practices and through cuts and whatever. But blood seemed to be required for transmission to occur by whatever means.
And so is it right then that from 1982 that was your understanding?
Yes.
Given that fact, were you concerned at the length of time it took for the Department of Health to produce the first AIDS leaflet? We know from other evidence that we've heard that was produced for distribution by the Department of Health on the 1st of September 1983. Do you recall whether or not that period of time between you knowing about AIDS and understanding that it required blood for transmission and the having available to you a leaflet to provide to your donors, whether that caused you any concern?
I think one has to remember that 1982 was a very different social situation to what we have today. We're looking back with hindsight, which is a different matter altogether. The public conception of AIDS, or as it came to be known as AIDS, was that it was a condition which was primarily linked to persons with certain practices, which we needn't go into details, and was not a matter involving the general public. And although blood was necessarily involved, yes, that the transmission seemed to be within restricted groups. And it was only as time went by that it realized that there were other possibilities to be considered, that in fact AIDS was transmissible, as was evidenced particularly from the populations in Africa. And it was realized that AIDS was becoming a more serious problem, and that the general public, which included blood donors, would have to take this on board. But we could not do that, bearing in mind the public fear of AIDS, which there was at that time. We could not do that until we knew exactly what we were up against, which of course in those days we didn't, and we had to draw up guidelines for donors which would not scare them rigid. So this is one of the reasons why it took a long time for an approved document to be produced, which would address this situation and would give the opportunity for those people in the dangerous activities to withdraw themselves as potential donors, while at the same time giving donors the opportunity of disclosing those risks.
So is it right to understand from what you've just said that in fact that length of time between when you knew about AIDS and the association with blood, or it being caused by blood, and the leaflet in September 83 didn't at the time cause you any concern?
What, the long time between the two?
Yes.
I think initially, from 1982 onwards, people used to think, oh, it's only going to be happening in these at-risk groups. which isn't going to be the general public, it's not going to be donors. But that's an attitude which obviously had to be challenged in due course.
And so was that your view then in that period 82 to September 83?
I think it's fair to say yes, because initially not an awful lot was known as to who actually could be involved apart from the so-called at-risk groups.
So is it also right to understand then from what you've said that before the leaflet became available in September 1983, Oxford was not taking any steps to screen out high-risk donors from donating?
The Oxford Centre was following the recommendations agreed by the directors that we would all the transfusion centres would follow the same system in terms of dealing with the advice, requesting information about at-risk activities. And it was felt very strongly that we should all go by the same rules.
We have heard evidence that it was left to the discretion of the regional transfusion directors as to how to distribute the first leaflet to donors. So there were three choices: the choice of sending out with a call-out card, handing to donors in sessions, or having them available in sessions. I'm just going to turn to a document, NHBT 20746, and just ask you about the practice in Oxford. So this is a letter from you, if we go over to the second page, to Dr. Wagstaff, dated 14th of June 1983. And if I just turn first of all to paragraph 6, the leaflet being prepared should be made freely available at donor sessions along with other BTS literature. We consider it should not be handed to each and every donor at the clerking desk for the reasons given in 3 above. So there we can see, is this right, that you took, as it were, the least invasive, if I can put it that way, option of leaving it available at donor sessions. Is that right?
That is correct. And the reason why we chose that route is that, bearing in mind public attitudes at that time, we felt that if each and every donor was given the AIDS leaflet, there would be some at least who would take exception to being, as they might see it, threatened. And it was felt more acceptable to adopt what we did.
Would you also accept that by taking the course that you did, that there may be some high-risk donors who never read the leaflet?
Quite possible.
And
but on the other hand, you're never going to stop some high-risk donors failing to declare what they've done.
But equally, there may be some high-risk donors who ended up donating simply because they didn't realise that they were in fact high-risk donors who should be deferred. Would you accept that?
If they didn't risk it, they're not going to disclose that, are they?
Can we look back at that letter then? Because you also give some, you set out your views about a question you were being asked. You were being asked a question about whether donors should be questioned about matters that might identify AIDS at sessions. So you say there, in response to your letter of 7th of June, we have reconsidered our approach to blood donor questioning with AIDS in mind. We do not consider the aggressive approach is justified. And are you there referring to the aggressive approach as oral questioning of donors. Is that what you were referring
Yes,
to?
indeed, yes. Because it was felt, and not only me, but others too, felt that what you might call aggressive questioning in an open session like that would cause far more trouble than was warranted.
And why was it thought that questions about, for example, sexual practices or lifestyle would be necessarily aggressive? Is there not a way of doing that isn't aggressive, that is neutral and for information purposes only?
Well, we could not see how that could practicably be done in an open donor session.
Do you think it would have made a difference if there had been the ability at donor sessions for there to be privacy? Would that have made a difference, do you think, to your view?
No, I don't think it would, on balance.
And then you set out your reasons in that letter, so we just have a quick look at that. You say there are no specific medical questions, the answers to which indicate presence of or liability to develop AIDS. Answers to non-specific questions about loss of weight, enlarged glands, night sweats, etc. are thought to be too vague, misleading and possibly, frankly, unhelpful. And then paragraph 2, even if specific questions were available, it's likely that the correct answers may not be offered where necessary. Indeed, the truth may be positively concealed. Just pausing there, that's something you referred to in your earlier answer. What was your view about the extent to which donors were in fact positively concealing risk factors when being asked questions, generally about their medical condition and specifically in relation to AIDS?
We're not saying in any way that that was the norm, just saying it is possible.
And had you come across instances where that had occurred?
Me personally, no. But nonetheless, the possibility remained.
And then you carry on at 3. The evidence to date suggests that those would-be UK donors most likely to develop AIDS come into the category of the 2 H's, namely homosexuals, especially the more promiscuous ones, and heroin or other drug abusers. The other H's probably do not apply for practical purposes. Routine questions of donors in the open forum of a clerking desk to seek information on their personal habits of this sort is considered to lead to rare disclosure of the truth or deliberate withholding of information or a very large number of annoyed, irritated, puzzled, upset donors to whom the questions do not apply. The resulting loss of donors as well as the aggro could be awful. And I think that's what you've just told us. And then you say 4, a sense of perspective should be maintained. The infections known to be associated with AIDS are far more prevalent in the USA, even in their so-called normal healthy donor populations. The incidence of donors with past hepatitis B, herpes simplex, CMV, syphilis, etc. in the UK population is so much at variance with the USA experience that the ill-defined questionnaire designed for American donors is considered inappropriate for the UK, at least on present evidence and at the present time. So I think you told us that you considered that the incidence of AIDS in the donor population was thought to be low, but here you're saying something slightly different, that actually in the population in the UK as a whole was also much lower than in America. Was that your understanding and belief in June 1983?
That was the belief at the time, and most of the information coming about AIDS was arising at that time from the States. And it was not seen as a massive problem in this country at that time. Obviously, things changed quite drastically over the next few years.
And then if we can just go over the page, please, just to pick up on the last penultimate paragraph. And then you say, if an inordinate fuss were made about AIDS, then possibly important other donor information may be at risk of being overlooked, ignored, not disclosed, etc. There are already very many conditions about which information is already sought. It seems most reasonable and appropriate that, at least as far as this country is concerned, AIDS should be dealt with like so many other disorders and be covered by the blanket ruling that there should be any medical doubts about the fitness to donate then that donor should discuss the matter with the medical officer in charge of the session. So what was your concern there, that if one elevated the question of AIDS by particular questions about lifestyle and practices and so on, one might be at risk of losing the other important information about other infections?
That was one of the concerns, yes. And I felt, as I said there, we felt to try and keep things in a reasonable perspective, bearing in mind what was known at the time.
And so those matters that you've just set out at paragraphs 1 to 5 go really primarily, don't they, to the question of whether or not donors should be orally questioned in a donation session. What was your rationale for taking the approach you did in terms of the handing out and dissemination of the leaflets? Why was it that you took the view that they should only be available at sessions rather than either being provided in call-up cards or individually to donors as they arrived at the session?
We felt that call-up cards was not the most appropriate way, not least because that would not cater for the walk-in donors. Secondly, we felt that if the leaflets were available on display for them donors to read before coming to the clerk, that was probably the most private or discreet way that could be addressed without causing too much anxiety, and then would give the donor the opportunity of disclosing or not as appropriate when they finally got to the clerk.
So if we then look at another document to see what was happening in 1984, could we go please to DHSC 0002241_002. So we have here a letter to the DHSS dated 28th of March 1984 from you, entitled AIDS leaflet, and you're replying to a request for information from the DHSS about how the leaflet is going in the region. And you say you've got stock of approximately 13,000 and you've issued approximately 1,000. What does that mean? What does issued mean?
1,000 leaflets were used at donor sessions.
Right. And then you say the rate of usage per month is now negligible. And then you set up method of distribution, leaflets displayed with other leaflets at sessions, at the clerking in table and at the tea table. And then you say effect on donor attendance, none as far as we can see, feedback, none for practical purposes. So just picking up a couple of those points, is it right to understand that by March 1984, donors were not picking up and removing from the tea table or the clerking table the leaflet? Is that what now negligible means?
Yes, I think one has to remember, again, going back to the fact this is now March 1984, which was a very different situation already from the situation in 1982 when there was so much public worry. By 1984, things were beginning to settle down somewhat, and most of the vast majority of the donors did not perceive that AIDS was quite as bad a problem as was first thought.
But of course, at this time, there's no screening in place, so the only sort of line of defence against high-risk donors is via the leaflet. Was it a concern to you that actually having them available didn't seem to mean that they were being read?
That's the one that could be argued, but I don't know whether that was the truth or not. And
then moving on then to the effect on donors of the leaflet. Is it right to understand that your concerns about the impact of the leaflet in terms of putting donors off and the consequence that would have for the blood supply hadn't in fact been borne out in your area, and that in fact the donors didn't seem to be bothered one way or the other about the presence of the leaflet?
I think that's a very fair assessment, yes.
So, moving on then to the second AIDS leaflet, which I will, and then that will bring us to lunchtime, I think. Can I take you first of all to a meeting from a meeting of the Western Division of the region of the Blood Transfusion Service of the 7th of December 1984, which we find at NHBT 0113565. We can see there you are in attendance. And if we turn over, please, to the second page of that document, we can see AIDS, the general problems of regional transfusion centres relating to AIDS was discussed. It appears that centres will not be able to test for HTLV3 antibodies for at least 6 months. The promised DHSS AIDS leaflet was not yet available. 4 centres have produced their own version for the time being. Concern was expressed at the lack of information from the DHSS, particularly in relation to heat treatment of factor 8. So, two matters arising from this. Were you, can you recall, concerned about the fact that the promised AIDS, second version of the AIDS leaflet was not yet available?
I do not recall exactly what the situation was at that time. I don't think we produced our leaflet independently, because I felt and I think I was not alone in feeling, that we should go by whatever was agreed nationally.
So you don't... oh, sorry.
So I don't think we would have set out to produce an independent leaflet of our own.
So you don't think you were one of the...
variants.
Sorry.
Sorry.
I spoke over you, sorry. You said, I interrupted you. You said it might...
I don't think it would be right, didn't think it would be right for us to produce a leaflet which might be at variance with what was ultimately thought as being correct elsewhere, or might conflict, perhaps, with the Department of Health document when it finally came. So
is it right then that you think it's unlikely that, or you weren't one of the 4 centres to have produced their own versions of the second versions of the AIDS leaflet?
I don't recall the Oxford Centre producing a leaflet independently, no.
And then if we turn then to two more documents before we break for lunch. DHSC 302159. So this is a Department of Health circular issued in January 1985 and is to regional health authorities. And if we go down, please, to paragraph 4, revised distribution arrangements, we can see there ministers have decided that it's essential that the revised leaflet be brought to the attention of each donor on an individual basis. This would normally be achieved by sending each donor a copy of the leaflet with his next call-up notification. It's realised that this may not be practicable for industrial sessions or new donors presenting at sessions. In these cases, alternative arrangements should be made to ensure that each donor is individually given the leaflet before any blood is taken. Displays of leaflets, while continuing to be useful, will not meet these new distribution requirements. Because the advice has changed significantly, the revised leaflet should be sent even to those who received the 1983 version. So just pausing there, do you recall whether or not that circular made its way to you and you were aware that there was an instruction from the Department of Health as to how how the second version of the leaflet should be distributed?
I must be honest, I do not recall that document. If I did see it, I presumably would have been required to act upon it, but I do not recall it, I'm sorry.
And then last document then, which before we break for lunch, is NHBT 2020745. This is a letter dated 20th of October 1989 to Dr. Gunson from the Deputy Director at the Oxford Centre. And it says, Colin, as you, has left to attend a meeting in New Orleans. In his absence, I've obtained a copy of his reply to Bill Wagstaff's letter of 7th of June. He does not appear to have replied to the second letter dated 6th of July. And he says this, I can find no evidence that the AIDS leaflet made available to blood transfusion centres during 1984 was formally issued to donors. Indeed, the first time the AIDS leaflet was sent to donors individually with their call-up card or as a handout at sessions was in March 1985. So there seems to be a gap, Dr. Entwistle, between the instruction coming from the Department of Health in January 1985 that the leaflet should be provided individually to donors, and that being put in place at Oxford in March 1985. Do you know why that was?
No, I'm sorry, I don't.
So slightly over time, I'm going to move on now to a slightly different topic in relation to HIV and AIDS. But now might be a good time for.
Yes, the only thing which arises possibly out of that last exchange is the health circular was addressed to regional health authorities. I think it was not addressed to regional transfusion centres as such.
Yes, that's correct.
And so presumably the route would be that it goes to the regional health authority, and if they think that it is of sufficient importance, as they ought to in the case of a circular, they would pass on the information to whoever needed to know. Would that be the way that it came to you?
Well, that's the way it should have come to me, but as I said just now, I do not recall having seen that document.
But obviously that might take a short while, but that's something which I shall have to consider. At the moment, I'm considering that when we should come back after lunch, and we'll make it 2 o'clock, I think. So 2 o'clock, if you please. 2 o'clock.